Welcome to our Persiska tumor board on myeloma. I'm Dan Pollier from the University of Colorado. I'm very excited to be with you today for some really interesting cases. I'd like to have our esteemed panelists introduce themselves, and just maybe starting from left to right, perhaps Dr. Nuka can begin.
Thank you for having me. I'm Ajay Nuka. I'm an associate professor at the Winship Cancer Institute. I am the director of the myeloma program, and I'm the medical director for the Winship Research Informatics Shared Resource.
Hi, I'm Peter Forsberg, also from University of Colorado, an assistant professor out here in the myeloma group with a specialty in myeloma and plasma cell disorders.
Thank you for having me. I'm David Schuster, and I am the director of the Division of Nuclear Medicine and Molecular Imaging at Emory University.
This is a 60-year-old male with an IgA kappa multiple myeloma who has extramedullary plasmacytomas with plasmablastic features. The patient has received 5 cycles of lenalidomide, bortezomib, and dexamethasone, got to a very good response with an undetectable monoclonal protein, and is now presenting to be evaluated for an autologous stem cell transplant. So the questions that we're going to focus on is just optimal management for a patient such as this in the newly diagnosed setting who has extramedullary disease with these aggressive features. And then, just from a diagnostic standpoint, what is the difference between this entity and something that we would call a plasmablastic lymphoma? Let's go through the details of this case. This patient presented with progressive nasal symptoms, and when we look at the images, you will see why. Performance status was 1, no real significant contributory medical, social, or family history. So this patient was worked up in October 2020 with a bone marrow biopsy that did show a kappa light chain restricted plasma cell neoplasm with plasmablastic features. We're going to take a look at the imaging in a moment, but the myeloma labs did, as we heard, show an M spike of 0.4 grams per deciliter and a light chain ratio of 3. And a biopsy of this left nasal mass that we'll look at did indeed show a kappa-restricted neoplasm with plasmablastic features that was CD43, CD79A, CD130A, and MUM1 positive. There was c-MYC positivity at 70% and a high Chi67. So there's a lot to unpack here just pathologically with our clinicians. So I might just take a few moments here. Dr. Forsberg, can you first just tell us a little bit about how you think about IgA myeloma in general? Do you find any differences in its presentation, in its likelihood to be extramedullary or not, in its how aggressive that disease entity is, or are there really no sort of prognostic clues that you get from the fact that this is an IgA?
Yeah, so I guess I think in terms of isotype of myeloma, whether it's IgA versus IgG versus light chain predominant, I think there's more similarities than there are differences. IgA myeloma may be a little bit more aggressive. IgM myeloma, which is rare, may have some slightly different characteristics, but that's 1 in 100 cases roughly. So more often than not, those isotype features, while it's something that often patients are very aware of, think of their myeloma as a sort of structure around that type, it doesn't necessarily tell us as much about what we anticipated for our future course and initial manifestations as some of the other things we look at, genetic characteristics, some of the labs that are present at diagnosis that are part of our, sort of staging system, maybe some of the pathological features like this plasmablastic, sort of identification, which would be something that would fall in the realm of orienting us to sort of disease aggressiveness, disease behavior. And then certainly, in this setting, finding a patient who has extramedullary involvement would certainly be something that orients us towards a disease phenotype that's more aggressive. So, less probably impactful in terms of that heavy chain type or light chain sort of characters. and more some of these other facets. But it is important in how we monitor, I would say. Sometimes monitoring IgA myeloma, it may not migrate as cleanly in your SPEP. So oftentimes you don't get as cleanly defined an M spike in IgA myeloma. So often we'll monitor the IgA level as one of our primary disease markers to a greater degree than we might in IgG myeloma, where you have a lot more IgG present from your normal baseline. So there are some slight differences in how we might monitor a patient over time and kind of initially assess their their monoclonal burden, but maybe not so much in terms of disease predictive features.
That's really helpful. Yeah, I was going to just follow up. So the fact that the M spike is 0.4 grams per deciliter, do you put anything into that in terms of this being an IgA case, or do you find that that's accurate, but monitoring that is inaccurate in a case of an IgA?
I'd say in IgA, it could be underrepresentative of how much how much monoclonal protein there is. It would be nice to see a quantitative IgA along with it to sort of get a better sense. But this would, it also could just be that the IgA is not that high, and this is a patient who doesn't have a huge burden of secretory disease. We do see, substantial heterogeneity in that regard, and that can, have implications in terms of monitoring and what you anticipate with low levels of disease, presence. In the blood. But I would say that there is a chance that this may underrepresent what he has. But so it would be nice to know the IgA level in these types of cases.
Great. And Dr. Nuka, I'm very, for the last at least 10 or so years, our lymphoma colleagues have been ordering, genomic testing like c-Myc, staining and things like that pretty routinely. Is this now a routine test you're ordering in myeloma cases as well, or is this something you would do in a situation like this where it was sort of a very aggressive presentation?
So it's not necessarily the myeloma presenting as extramedullary disease happens infrequently. It's not uncommon, but it happens very infrequently. In a situation like this, specifically where there's an entity with something like a plasmablastic lymphoma versus differentiation to extramedullary myeloma with plasmablastic features, absolutely we do most of the tests that typically our lymphoma colleagues do. So, but this is not the normal course that we typically take for all myeloma cases.
Got it. Okay. So that makes sense. So on a typical myeloma case, nobody's ordering c-Myc, but in a myeloma case such as this, in which there is, a presentation with such dramatic extramedullary disease and a lymphoplasmic lymphoma is sort of in the mix. You would do a similar workup. Okay. Well, yes. So maybe the next thing to do would just be to take a look at this imaging. So here's a CT of the nasal cavities. Maybe Dr. Schuster can take us through this.
Sure. And just to remind ourselves, there are elsewhere extensive lytic lesions. So here we have a large left nasal cavity mass, but it's crossing the midline and it's destroying bone turbinate. It is also extending into the left ethmoid sinus. And it looks like it's obstructing completely the left maxillary sinus and probably at least partially obstructing the right maxillary sinus as well. So this is a highly aggressive lesion, and that kind of fits with the clinical picture as well.
And Dr. Forsberg, when you have, I understand that this is uncommon, but when you have extramedullary involvement of a plasma cell neoplasm, are there certain places that there's tropism for outside the bone marrow, besides, of course, the bones and I suppose the kidney that seems to be more common? I mean, is this in an uncommon situation as extramedullary disease, is involvement of the nasal cavities even less common, or is it just, it could be anywhere?
Well, it kind of can be anywhere. I'd sort of say, in our realm of extramedullary plasmacytomas specifically, plasmacytomas of bone are more common than extramedullary. And if you have isolated extramedullary plasmacytoma is actually the most commonly involved area outside of the bone is the nasopharyngeal tract. So it's not an unusual place for solitary plasmacytomas to happen. Extramedullary myeloma can happen in different, I guess maybe maybe slightly different patterns in different disease circumstances. Oftentimes, we probably see more often extramedullary disease in late myeloma, patients who've been, heavily pretreated and have received multiple myeloma-directed therapies that sort of change the genetic profile of your myeloma and make it easier for it to live outside of the bone marrow stromal environment. And in those circumstances, we often see fairly broad involvement. Sometimes you can get liver or spleen involvement. But it can be pretty diffuse. So nasopharyngeal is not, an entirely unusual place, especially in that solitary plasmacytoma outside of bone scenario. But it is important to think, plasmablastic lymphomas also are commonly associated with oral lesions. So in considering this case, that would be a thing to think about, is that is an area where plasmablastic lymphoma may be involved and may sort of raise your consideration of that entity.
Yeah, I suppose maybe Dr. Schuster would have a perspective on that question as well. I'm guessing you've seen it all. Anything that kind of comes down to any sort of patterns for you that would be helpful for clinicians?
Yeah, I agree with Dr. Forsberg that we tend to see it in the more advanced cases. It's interesting that the nasal cavity has a lot of blood flow. And generally, patients who have vascular metastasis can go to the nasal cavity, but lymphoma, melanoma are also on the differential. But obviously, we know this patient has multiple myeloma. In terms of the best way to work something up and looking for extramedullary disease, I think this is where FDG PET really shines. If you have a solitary plasmacytoma, MR is going to be fine. So the extramedullary disease, if you really want to screen for that, I think the FDG PET is really the way to go as well.
That's a good point, and in fact reflects reality here. So this patient did have a repeat bone marrow biopsy, which was normal cellular, but with 10% involvement of plasma cells that were not light chain restricted, normal cytogenetics. The PET indeed did show a left ethmoid nasal cavity mass with that was avid with an SUV of 7. So before we go to treatment, just the bone marrow findings, Dr. Nuka, anything surprising there to you in that there was 10% involvement but not light chain restricted? And then how often do you get normal karyotypes with this type of disease? And I guess a third question, sorry to pile on, is this helpful, or how could this help make that distinction between the between the plasmablastic lymphoma?
So there are several ways. Like I'll start with the differentiating features of what exactly we look for in the plasmablastic lymphoma, and it starts with the clinical presentation. So as Dr. Forsberg alluded to before, plasmablastic lymphomas are more commonly seen in the mucosal areas, and more commonly HIV associated, more commonly Epstein-Barr virus associated. So when you look at the entire clinical picture, when you see these plasmablastic lymphomas, they should have lymphadenopathy elsewhere as well. So that is not the kind of a picture that we're seeing in this patient. At the same time, we see a clonal population in the marrow. We do have a measurable paraprotein. We do have the extranodal or the extramedullary mass sitting in the sinus regions. All of these are pointing towards more like an extramedullary myeloma with plasmablastic features. So from a diagnosis perspective, I do not have any criteria that is suggestive of this to be a plasmablastic lymphoma, but it is very good to clearly differentiate between both of these cases for this reason, because the treatments can change.
Got it. So I know I buried you in questions, but how common do you have no karyotypic abnormalities in just a regular case of multiple myeloma?
So we only see 20 to 30% of the times you see them to be abnormal, or even it is possible. You see the results. So 70 to 80% of the times you don't see these cytogenetics have to be done on metaphase karyotype, they have to grow. And myeloma is not one of those proliferative neoplasms that you see them to grow. So that's one of the main reasons why we use the FISH panels in addition to cytogenetics, so that we can know whether the patients have, or the patient's myeloma exhibits those specific known genetic abnormalities that go along with myeloma. So there is a common panel that is accepted because of this deficiency.
And how often with FISH do you see no chromosomal abnormalities?
Around 30% of the times.
Okay. So the metaphase cytogenetics are certainly limited in myeloma, but very important to get the proper FISH testing, because in more often than not, they do have a chromosomal abnormality detected by FISH. So this patient was treated with cyclophosphamide, bortezomib, and dexamethasone, and then switched to lenalidomide, bortezomib, and dexamethasone, and ultimately completed 5 cycles of that therapy, and appears to have had a very good response. But getting to back to our expert panel, in Dr. Forsberg, this is a case where the treatment that was administered seemed to have worked very well, at least in terms of getting the disease under some control. How would this differ, if at all, from your approach to such a patient?
Yeah, so I think, certainly if you feel, sort of once you feel comfortable with the diagnosis of myeloma and differentiation, sort of working with pathologists, sort of evaluating those features that may point towards plasmablastic lymphoma versus myeloma, once you sort of feel comfortable with the diagnosis of myeloma with plasmablastic features and, in this case, extramedullary disease, you're dealing with what we would consider to be a high-risk myeloma case. Somebody who's likely to have a more aggressive disease course, but wherein your treatment sort of, stems from your core myeloma therapeutic approaches, but maybe geared towards a more aggressive trajectory. So this would be a patient where, starting with VRD, CyBorD, it sounds like he got 1 cycle of CyBorD and then transitioned to lenalidomide, bortezomib, dexamethasone as a primary therapy for his induction. You could also think about, in a case like this, daratumumab with VRD, some folks would also still use carfilzomib containing regimens as their preferred proteasome inhibitor in high-risk cases. But I might favor starting initially with something like dara-VRD for, a number of cycles to try to induce remission. Once you get remission, achieving remission in high-risk myeloma cases is not necessarily the problem. Oftentimes we're able to get good responses in patients, but the problem is those responses are not sustained. So in this case, usually we would be using our initial combination therapy with 3 to 4 agents, and using that as the first step of a multi-step treatment platform to try to get control, and try to achieve somewhat durable control. Because the problem is early relapses are a very prominent sort of scenario in patients with a presentation that has some of these aggressive types of features. So usually we'll be starting with one of those combinations for 4 to 8 cycles. Some differences in opinion in how you do it, but essentially to induce remission, usually followed by stem cell transplant in an eligible patient with melphalan conditioning. And then I would favor a multi-agent maintenance approach in this patient, usually something that includes a proteasome inhibitor like bortezomib or dexamethasone, as well as lenalidomide with some steroids. So we'd be thinking of a pretty, sort of intensive long-term approach with induction, transplant, multi-agent maintenance to try to stabilize this control that you've achieved, knowing that that's often the hard part in these aggressive types.
Great. Dr. Nuka, any differences in your approach or anything that would be important for the audience to know about a case that like this that from a treatment perspective that we haven't really discussed?
So I agree with Dr. Forsberg in every aspect. So there is more and more data that is coming up that high-risk patients, which we both agree that this patient is, even though we don't have the FISH to suggest, but this patient is behaving like a high-risk disease. And this patient, if not treated properly, will soon suffer an early relapse. So the idea is to push that relapse to a later time. And how can we do this is the question right in front of us. And using the most potent treatments, like using carfilzomib-based combinations in the upfront setting. And we do have a clinical trial exactly looking for the same aspect in the post-transplant maintenance setting with carfilzomib, pomalidomide, and dexamethasone for an extended duration of time. This is also confirmed by a recent trial called the Forte trial, where the Italians had shown using the KR, or carfilzomib and lenalidomide dexamethasone, as maintenance is very beneficial for these high-risk patients compared to a single-agent lenalidomide. So there has been a lot of debate in the past whether would the single-agent lenalidomide be good enough as a maintenance agent among these high-risk patients, and that trial has clearly shown that patients will be able to maintain those responses for longer period if you use a combination approach, just like how Dr. Forsberg talked about.
That's great. Okay. Well, so just to summarize a bit, for this very challenging case of an extramedullary myeloma with plasmablastic features, there's a consensus that an aggressive upfront treatment approach should be taken with incorporation of many of these new novel therapies, carfilzomib, daratumumab, get the patient into a remission and take them through an autologous stem cell transplant, and then maintain them aggressively in an attempt to get the longest duration of a response possible. With respect to the question of how to differentiate this from a plasmablastic lymphoma, it sounds like that is very challenging. I think that there are a lot of, it sounds like very biological overlap here. But one suggestion was to look at the overall context in the clinical presentation and to see if there are more lymphomatous clinical clues such as lymphadenopathy or other sort of more radiographic evidence of a lymphoma that would push the person more down that diagnostic road.